CAD systems can assist doctors in the interpretation of medical images. CAD is an interdisciplinary technology that combines elements of artificial intelligence and computer vision to process radiological images. We use this system to detect, quantify, and classify tumors. In other words, CAD systems provide diagnostic aid to physicians so they can make better decisions. CAD is based on the recognition of highly complex patterns. While CAD goes through several steps to analyze digital input data, most CAD for thyroid ultrasound imaging aims to classify nodules. Machine learning methods are used to analyze imaging data, which can then be used to assist the decision-making process. When deep learning technology is applied to machine learning, CAD performance further improves. Full CADs have been approved by the FDA for thyroid nodules. SDetect is a deep learning-based system that is integrated into vendor-specific ultrasound machines. It has been widely studied among the 4 CAD tools. AMCAD is a Microsoft Windows-based software that analyzes static images of thyroid nodules after image acquisition. Chaos DS is the most recently approved CAD for thyroid imaging. It is integrated into radiology workstations and interfaces with both PACS and reporting software. MedoThyroid automatically segments the thyroid and thyroid nodules. It is not yet used for risk stratification, but current efforts are underway to develop function to do so. 2 non-commercial CAD systems are available at this time. The ThyNet was trained with about 18,000 images from 2 Chinese hospitals, and Sarah was trained with more than 13,000 images from a Korean hospital. There have been many investigations on the diagnostic performances of CAD for the classification of thyroid nodules on ultrasound. In my talk, I will first compare the diagnostic performances of CAD alone with the diagnostic performances of readers alone. Then, I will compare the diagnostic performances of readers alone and the diagnostic performances of readers who receive CAD assistance. Among these matrices for diagnostic performance, I will focus on accuracy in this presentation. In most studies, the accuracies of experienced physicians were higher than those of the CAD systems. In contrast, the accuracies of inexperienced physicians were similar to those of the CAD systems. For experienced physicians, accuracy did not increase with CAD assistance, and in some cases, even decreased. In contrast, the accuracies of inexperienced physicians increased with CAD assistance. So, experienced readers show similar or lower accuracy with CAD assistance than without. However, inexperienced readers show higher accuracy with CAD assistance than without. Therefore, we can infer that CAD can help inexperienced readers make better decisions. To give you a real picture of what these findings mean, I will go through several cases. This 74-year-old woman visited our hospital to undergo FNA. After suspicious ultrasound features were observed on a screening ultrasound performed at an outside clinic. Here. The patient also brought ultrasound images taken 2 years before. When we compare nodule size between two outside images, we can see that there were different interpretations about nodule margin. How would you draw the nodule margin? Here or here? I've brought a video clip of the ultrasound to give you an idea of where the nodule begins and ends. This is a transverse scan. This is another video clip of the same nodule. It is a longitudinal scan. So, how would you determine this nodule's margin? I read this nodule as including the surrounding isoechoic area, and third, this is a hypoechoic change from internal degeneration. The lesion was diagnosed as benign at FNA. This image here is not a comparison of static images. Two physicians performed real-time ultrasound on the same nodule and saved what each physician regarded as a representative image of the nodule. One physician thought this picture was a representative image. The other selected this image. Although the two readers reached the same final assessment, we can tell from the ultrasound images that the two readers analyzed the ultrasound images in different ways. Theta values also differed between the two readers. So from the cases we've just seen, we can confirm that CAD values can differ even for the same nodule. As these differences result from the choices ultrasound performers make, the diagnosis of CAD alone is consequently more accurate in experienced readers compared to inexperienced readers. In short, experienced physicians with CAD alone showed higher accuracy than inexperienced physicians with CAD alone. The following cases will show how final assessments change when CAD values are available. Do you think this is cancer or not? The 5 physicians who participated in this study had intermediate levels of experience with thyroid ultrasound. All assessed the nodule as benign, and the nodule had a low CAD value. The final diagnosis was benign. What about this nodule? Do you think this is cancer or not? All 5 physicians assessed it as benign, but the CAD value was positive. Would you change your assessment after seeing the CAD result? The final diagnosis was cancer. Now, what about this nodule? Two physicians assessed it as malignant, while the other 3 physicians assessed it as benign. The CAD result was positive. What would your final assessment be? This nodule was confirmed as cancer. We have only viewed a few cases, but I think you can already see that CAD values vary according to the user. While most readers showed improved accuracy after CAD assistance, some showed worse accuracy with CAD assistance. Therefore, the diagnostic performance of CAD varies according to the user of the CAD system. Even though ultrasound can be the best tool for classification of thyroid nodules, the subjectivity of ultrasound is a major limitation. Having experienced ultrasound performers can overcome this limitation, but it cannot be avoided until now. As you can see here, inter-observer agreements among 5 readers were substantial without CAD. With the aid of CAD, kappa value was increased. So, with CAD assistance, inter-observer variability can be decreased. As I stated earlier, CAD can help the diagnostic performance of inexperienced physicians. Now, what things do we have to keep in mind when providing CAD assistance to inexperienced physicians? Here are a few examples. This 59-year-old woman had an asymptomatic thyroid nodule incidentally discovered. What would your assessment be? Cancer or not? The CAD value was so high, but it was an esophageal diverticulum. This 45-year-old woman underwent ultrasound for neck pain and was referred to our institution for evaluation of a large thyroid mass. Here is the mass. The CAD value was near 90%. It was confirmed as an abscess due to esophageal perforation. This hyperechoic area was due to air, not calcification. Here, we have a 62-year-old man who was referred for FNA at our institution after a calcified thyroid nodule was detected on screening ultrasound. Again, is this cancer or not? The CAD value was not high. However, FNA was indicated for the nodule according to 3 guidelines. The nodule was diagnosed as a piriform sinus fistula. The hyperechoic area was due to air, not calcification. This 31-year-old woman was referred to our institution after a suspected thyroid or parathyroid nodule showed up during her medical checkup. The CAD value was very high, but it was a cricoid cartilage, not an abnormal mass. These images show the ultrasound findings of an esophageal diverticulum according to time. The CAD value fluctuated. In some images, the malignancy rate was quite high. For beginning readers, CAD is a way to improve diagnostic performance. However, the CAD systems of today were trained with thyroid nodules and calculate the malignancy rate based on the assumption that all images are of thyroid nodules. Therefore, when the listening question is not a thyroid nodule and high malignancy values are calculated by CAD, an invasive procedure may be performed at the lesion, which can even be a leave me alone lesion. From what I have reviewed today, I think you will agree that CAD can benefit beginning readers, but that it cannot yet differentiate the thyroid nodule from nearby lesions. This part of the diagnostic process is still completely dependent on the skills and experience of the performing physician. Therefore, beginning physicians with less experience must not expect CAD to do everything or know everything. Ultrasound performers need to have a deep understanding of normal thyroid adjusted structures and ultrasound physics, as no machine can yet completely replace the humans who perform ultrasound. Thank you for your attention.